Hello and welcome, everyone. Please note that this session is being recorded. We are pleased to offer French simultaneous interpretation for this session from the team at Boost Lingo. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If at any point you need support at any time during this webinar, you can reach out to one of our tech support using the chat feature. English participants may choose to view the auto-generated live transcripts or subtitles throughout today's session by clicking the CC Live Transcript button from the Zoom menu at the bottom of your screen. French subtitles cannot be viewed live, but we are pleased to make both English and French captions available on the session recordings. I'm Beverley Pomeroy, and I'm a parent, a grieving parent, a sibling, a partner, and a friend. I am first generation newcomer of Irish, French, Geordie, and Austrian descent. My ancestral names are Pomeroy, de Pomois, Sillery, and von Birch. I'm a queer researcher, non-binary, and use the pronouns they, them. And I'm a new senior program lead here on the Patient Safety, Equity, and Engagement team at Healthcare Excellence Canada. I'm pleased to be your host today. Healthcare Excellence Canada is a new organization launched in 2021 with a relentless focus on improving healthcare with and for everyone in Canada. I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, I acknowledge that I'm hosting this webinar from the unceded and traditional lands of the Snuneymuxw people, colonially known as Gabriel Island, a southern Gulf island off the west coast of Turtle Island, quite literally in the middle of the Salish Sea. I want to thank Indigenous elders and knowledge holders, past, present, and emerging, for stewarding these lands and for contributing Indigenous ontologies and epistemologies towards more holistic healing and wellness. And I'm committed to expanding my worldview and relation, and I'm humbled for the generosity of the wisdom that is going to be shared today. Our Spotlight series is an opportunity to have focused, constructive discussions and explore solutions to make improvements last as we work together to shape the future of quality and safety in healthcare across the country. Today's episode is titled Patient Safety, Cultural Safety, and Anti-Indigenous Racism. As part of our work on patient safety and equity at HEC, we're adopting a new approach to patient safety. In rethinking patient safety, we believe that everyone contributes to patient safety. Together, we must learn and act to create safer care and reduce all forms of healthcare harm. This broader concept of harm, including racism, anti-Indigenous racism, cultural safety, and anti-racism are essential to supporting safer care. Unfortunately, First Nations, Inuit, and Métis people and communities continue to face racism in healthcare. During today's session, you'll hear a list of experiences from providers and leaders on experience of anti-Indigenous racism within care, specifically perspectives from First Nations, Inuit, and Métis people. We aim to take a distinctions-based and strength-based approach for our conversations today. We invite you to share your question during today's webinar using the question and answer feature in either English or French. We have a large number of registrants for this webinar, and we expect many questions. We will do our best to answer all questions. However, we may not have enough time to reach them all. As we jump into the webinar, we want to ensure that we take good care during our time together and recognize that these topics may be difficult for some. I invite you to bring in the foreground what helps you ground and stay in the moment. And we invite you to do what you need to do to stay well, including taking a break or a breather. And we've added some mental health resources in the chat. I would now like to invite Monique Manach, Algonquin knowledge carrier who supports and guides our work at HEC, to open us up in a good way.
Quick way. Good, well, for us, it's, well, just turned good afternoon. I'd like to, first of all, I am situated on unceded, unsurrendered Algonquin territory. So I would like to say, Pajashig, welcome to our territory. Monique Manach and Dishnakas, Kittikinikanishnabek and Dochiba. My name is Monique Manach, and I'm a member of the Algonquins of Barrier Lake. And I just wanted to say a few words this afternoon for me, and this morning for others across Canada, that when I think about, anti-racism and creating safe spaces, I keep coming back to the idea of how we're all human beings. And we have a creation story that speaks to that, actually. When the Creator had decided to make human beings, she went to the rest of creation. And you see, she had made everything else first, all the plants, all the animals. We say the ones who fly, the ones who swim, the ones who crawl. She'd made them all first. And so she went there, and she went to them and she said, I'm going to make human beings, but they're going to need your help because they won't be able to see very well or hear very well. They're not going to have fangs or claws or fur or feathers. And so the rest of creation got together and had a discussion. Are they going to help them? How are they going to help them? What's going to happen? So they decided what they were going to do, and they came back to the Creator and they said, okay, we will help these human beings. And so the Creator made a sacred fire. And into that sacred fire, every single member of creation stepped up and they gave a gift, an attribute, a skill. They say from the white pine, we learn patience because it takes so very long for the white pine to grow to its full height. They say from the wolf, we learn about compassion. We learn about family because of the way that the wolf pack takes care of each other. When a wolf pack is on the move, it's the old ones who lead. They set the pace, because if the young ones set the pace, then they wouldn't be able to keep up. So it's the old ones, and the rest take care of each other and protect the pack. They say from the eagle, we learn love. We learn clarity, not just physical clarity, but clarity of mind. It's the eagle who takes our prayers to the Creator because the eagle flies the highest. And they say even from lice, we can learn something. And they say from lice, we learn persistence. So when every single member of creation had given a gift into the sacred fire, a woman and a man stepped out, knowing in their hearts and in their minds and in their souls and in their bones that we need the rest of creation to survive. And we wouldn't be here without them, and we owe them a debt of gratitude. And for me, this story talks, it isn't that, the Creator only made Indigenous people, or they only made white people, or they only made Asian, or our Black brothers and sisters. She made all of humanity, and we all share these gifts, all of us, in different amounts. Everyone has their own journey to go through. Everyone has their own gifts that they need to develop, and also gifts that they need to incorporate more into their lives. And I think when we deal with people, especially people who are ill on a daily basis, on a reoccurring basis, it would really help us to understand this, that no matter who comes to us, they have gifts. And even though they may not be presenting them very well at the moment, we need to recognize that. And we need to connect on that human level. They say, with Indigenous people, when non-Indigenous people meet, when I'm out in the mainstream, people always say, "Hi, how are you?" Which is lovely. In the community, in the Indigenous community, we say, "Hi, where are you from? Who's your family?" Because we're looking for that community, that connection. Our paradigm is based on relationship. Having a relationship with whoever we're dealing with, knowing, even understanding those gifts, that connection. And so for me, that's something I always try to remember when I'm working, or when I'm out, or even when I'm just standing in line at the cashier and it's taking a long time and people are taking a long time. You gotta try to, I try to keep that in mind. Sometimes it's not easy. Patience is a gift that I'm working on. But if we can keep that in mind, I think it helps. It helps make our day. It certainly helps make the time or the situation that the people that we're dealing with. It certainly helps them, and it helps for a more positive outcome. And I think it helps too that it helps us look beyond stereotypes. And I think that is so important. That is the most important thing, is to look beyond stereotypes and look to the human being. Who is this person standing in front of you? This human being who is sharing this existence on this physical plane. So I would like to open this space, making it a sharing space, a learning space, a space that's full of joy and wisdom, and a sacred space, a space where we can feel safe to really share what's in our hearts and on our minds. And to do that, I'll just say a few words to the Creator. Kachimi Gwich Jemnado. Thank you, Creator. Thank you for everything you've placed in our homelands that help human beings to live well. We acknowledge and honor the water, the lakes, the rivers, the streams, the oceans. We acknowledge and honor the birds, the animals, the fish, and all the good human beings. We acknowledge and honor the plants and the insects and everything that helps the plants to grow. We thank you for the sky world, and we thank you for our mother, the earth, and all the things that live beneath the surface of the earth. We acknowledge and honor our ability to bring peace to one another, especially during times of trouble and anguish. We ask that good words are spoken here today, strong words that impact us spiritually and emotionally. We ask that you help us reach the wisdom of our ancestors and to bring that wisdom into this space, and to help us bring that wisdom into our daily lives and share it with our friends, our family, our communities. We remember our friends and family who are ill, whether physically, mentally, or through addictions, and we hope they have a good day today and that they return to us soon as role models and as mentors. And we remember to live our lives with great respect for all living things. Kachimi Gwich, Kachimi Gwich, Kachimi Gwich, Kachimi Gwich. Thank you very much. I know it's going to be a wonderful discussion today. Thank you.
Monique, thank you so much. And what a great way to start our time together today. And just as a reminder, or just to bring awareness, in the chat, we have posted some resources for wellness for anybody who does need them for our session today or after. So now I'd like to introduce and welcome our panelists today, Reagan, Bobbi, Alika, and Lynn, to come on camera. Great. So it's not just my face up here. So thank you all very much for being a part of today's session. And maybe let's just do some introductions and so everybody gets to know who's here and who's speaking today. And so maybe Reagan, I can start with you today, please.
Absolutely. And thank you, Monique, for starting us off in a good way. I'm going to attempt to speak some Michif, so apologies to folks that may be online that will know that I'm butchering this. It's part of my health and well-being, that reclamation. So, ki tatamskatin nawao ni wakamakanak, ni kichi yamatin treaty 6, mina li meti nekinani. Tanse Nia Oma Reagan Bartel. So I acknowledge all of you, my relatives, and honor Treaty 6, where I'm located in Amiskwitchi, Wisconsin, and the Métis homeland. My name is Reagan Bartel. I have the pleasure of being the Director of Health for the Otipemisiwak Métis government for the Métis Nation within Alberta. I have about 17 years of bedside experience as a frontline nurse in the Royal Alook Hospital ICU before I moved into public health, where I can support my community in a different way. So it's a pleasure to be here, and I look forward to the discussion.
Thank you so much, Reagan. And maybe, Bobbi, I can get you to do an introduction for us, please.
Hi, My name is Bobbi Paul-Alook. My pronouns are she, her. I am tuning in from my home in High Level, Alberta, which is in the northwestern corner of the province. Likely very few of you know where that is. Um, I'm also here coming from Treaty 8 territory, home to many First Nations, including the Tall Cree, Beaver, Danita, Little Red, and Little Red River Cree Nations, as well as home to the Métis people of the Métis Nation of Alberta and the Paddle Prairie Métis settlement. I am a Métis daughter, wife, mother of 5, and grandmother of 2. And I'm originally from Fort Vermilion, Alberta, which is the oldest settled community in the province. I am a registered nurse of 20 years, having worked in various different areas of the healthcare field, from frontline nursing to management. I'm also the newly appointed Secretary of Health and Seniors for the Otipemisiwak Métis government for the Métis Nation within Alberta. As an Indigenous person, the topic of cultural safety is of utmost importance to me. About 4 years ago, I made the conscious choice to become more involved in my community as a Métis person and a Métis matriarch, and as an advocate for my people. Shortly after the was released in 2019, I picked up my then 9-year-old daughter from school, and on the ride home, she asked if it was true that she had heard about this report, and if it was true that Indigenous women and girls were more likely to be at risk for these horrible things happening to them. And I answered that yes, unfortunately, it was true, that it wasn't right, but it was true. And then she asked me, Mom, I'm Indigenous, right? And I said, yes, my girl, you are. And the instant look of terror in her face was heartbreaking. And she said, can you lock the doors? And we were driving down the road. And in that moment, I realized how terrified she was to be who she was, because of the situation that we live in Canada today with racism and violence against Indigenous women. So it was really at that point that I decided to make that conscious choice to give her the tools that she needed to overcome that fear and to find strength in who she was as a way of combating that racism. And so that's what we've done. We have accepted our culture, we have promoted our culture, and we've really brought it into our home and into our communities. And yeah, that's kind of my connection to this topic.
Thank you so much, Bobbi, for sharing that. Really appreciate your story and sharing. Alika, maybe you'd like to introduce yourself next, please.
Sure. So thanks for everything that's been shared so far. My name is Alika Lafontaine, originally from Saskatchewan, Métis, that traces my ancestry back to Red River. My mom's from the Pacific Islands, the island of Tonga, so I have mixed Indigenous ancestry from different places. I grew up in Saskatchewan, Treaty 4, and lands of the Métis. I currently work in Grand Prairie, Alberta. We have pretty good representation, I think, from Alberta on this panel today. I've been up here for about 12 years. My practice is in anesthesia. I've also been involved with medical leadership across the country, most recently is coming off being president of the Canadian Medical Association, and have had the great opportunity to be involved in many different projects related to Indigenous health among First Nation, Métis, and Inuit peoples. I guess my connection to the topic here is I've personally experienced racism myself, with been with my family as they've experienced things. And as a clinician working at the bedside, like other folks on this panel, we kind of see it every day. And I think that these types of conversations are really, really important, because if we don't bring front of mind people's lived experiences, how can we improve them? And I think one of the things that really comes out in the way that patient safety is framed now is that it's not just about the absence of harm, it's actually having people feel safe. And that, physical harm is not the only type of harm that people experience today in the health system. So really excited to be a part of this conversation. And that is me.
Thank you so much, Alika. We're super grateful that you're here today to share both your story and your experience and professional acumen as well. And Lynn, I would love for you to do an introduction as well and share who you are.
Lynn Kilabuk, originally from Panelist, Nunavut. My mom Inuk from Panelist, and my father a settler. I come from a family in my community who are very dedicated to helping the community and being able to provide. So our whole family has been known to either help politically or just within the community. My career started in working for our regional Inuit Association, then led to our programs and economic development, then construction, then economic development in general. Then our family moved here to Ottawa. I'm on Algonquin territory. And we moved down here because my son couldn't get the services that we would have got if we stayed in the north in the Iqaluit. So we moved down here so he could get an education. He has severe learning disabilities. So I understand having to fight and advocate for yourself, as well as my mother was the youngest of 9 children. So a lot of my aunts and uncles were like my grandparents, and listening to how they had to go and receive patient care. And of course, living in a remote Nunavut community, you have no choice but to fly out. Maybe not see the same doctor you saw the first visit and re-explain everything that you did have to do 20 different times to 20 different medical professionals. So with moving down here, I had the great opportunity to work for our economic development arm's medical boarding home and lead that. And with my dedication to wanting to help my fellow Inuit, go from an organization of 24 staff to 94. So the boarding home itself grew quite quickly within the 5 years. So changing that, as well as changing how we approach how people feel comfortable with coming down to Ottawa for medical care. And of course, just having that connection with, have gone through the different communities within the Nunavut territory in my previous roles in my jobs over the last 15 years, gave me a unique understanding of how hard it is for people to get the medical care or attention that they do need. And then just listening to them on how their experiences while they're down here. So I hope to as well shed some light. I do hope that we all learn from this as well. I want it to be a positive experience. I'm always excited to hear more positive experiences and changes that happen. While I was at Larga, I was as well on the Ottawa Hospital Indigenous Cancer Care Committee. So that gave me a great insight, as well as working with local Inuit organizations on that committee. So I look forward to this chat today.
Thank you so much, Lynn, for sharing and for being here today and really sharing that wisdom of experience that is so important for all of us to hear. So we're going to ask a few questions, and really it's about exploring sort of some connections around cultural safety and anti-racism and this piece around patient safety. And maybe, Bobbi, I can start with you. This is going to be like a big question, a lot to it. But really just sort of to begin this dialogue today is really sort of describe to me what cultural safety looks like for you and to you in reference to what we're discussing today.
Sure. I think cultural safety requires kind of a combination of actions that are meant to create a space where individuals, families, and communities are supported without judgment. It's a process where those who are providing care within the system are meeting people where they're at and using a trauma-informed approach that ensures that practitioners are taking into account their own biases, potential lack of information, anything that might affect their practice and their service provided, so that people are provided with the care that that they deserve and that every Canadian deserves to have. Cultural safety also is about, I think, reducing stigma and stereotypes and lessening power imbalances, and trying to really look at being client-centered and putting the client, family, or community even at the center of that support or services, and using their strengths that are inherent in that community, culture, family, or individual, to support them in their journey towards health. More importantly, or maybe not more importantly, but also very important, I think cultural safety is about the lived experience of the client and patient. It requires respectful interactions with the client in an environment free of racism and discrimination. We need to remember that it isn't a one-size-fits-all list of to-do items, and it may look different for different communities, for different nations, or for different people. I'm more inclined to think about cultural safety as reflecting on how does it feel for the client over how does it look. We can do all of the things. We can have a welcoming environment, as far as, Indigenous art on the walls, and it looks like we're doing all of the things, but if somebody comes in and they don't feel welcomed, if they don't feel accepted, if they don't feel understood, respected, supported, or safe, that's not cultural safety. That's kind of lip service, which I think sometimes happens in our healthcare system. We focus more on what it looks like than what that lived experience is.
Great, thank you, Bobbi. I love how you've sort of, yes, patient, client, family, and then community, to sort of put that in the center, like that whole being and whole person, and make it strength-based. And I really like the idea of lived and living experience, and reflecting on what lived and living experience is from a feeling, from that embodied approach to the work that we're doing. I think often with lived and living experience, we share story, but where is that feeling? How do we sort of embody that approach, or think of that embodied approach when we're looking at lived and living experience to help frame the work that we're all doing? So thank you for sharing that. Maybe Alika, I'll toss it over to you. And rethinking patient safety really does provide sort of broader understanding now of what we're considering patient safety, and harm, rethinking harm, including harm related to cultural unsafe care. And I'm just wondering if you can describe how you see cultural safety fit within the concept of patient safety, and anti-Indigenous racism within the concept of patient harm. And so just sort of curious around that from your perspective.
Yeah, it's a good question, and thanks for the overview of cultural safety, Bobbi. That was I think pretty comprehensive. I think when we have talked about patient safety in the past, it's kind of like harm to body. So there'd be this threshold at the bottom, and if you crossed it and created harm, that was undesirable. So you try and kind of keep below that threshold. And I one of the things that we've realized, I think, in patient safety over the last few years is that to truly get that avoidance of harm, you have to think more than just thresholds. It's more than just ensuring that the physical aspects of patient safety don't end up happening, and looking more broadly at the environment, the potential for harm, people's feelings of being safe. And these sometimes sound like abstract concepts, but I don't think they really are. If you think of yourself as coming to see a provider, in order to optimize your opportunities to get better, you have to have different components, right? Like you have to be able to communicate openly with the person across from you. you need to have a level of trust with them that when you tell them things, they're actually going to help you kind of down that path as you try and find what you need in the healthcare system. Keeping your mind open as a provider that, there may be other things going on, and picking up on those. All of these things are part of a culturally safe environment. If someone comes in and feels that they're engaging with someone who's not projecting hostility towards them, that they feel like things that are tough to talk about and share, but are relevant to the medical experience, they can actually be open and actually say things about it. That leads to a much different place than coming to a culturally unsafe environment where you may not have immediate threat to like limb or life. You may fall below that threshold of harm that we've thought about in the past, but you're not really creating that environment where you can thrive, that environment where you truly are as safe as you can be. One of the things that I appreciate in working with folks who really provide culturally safe environments is that it's the team approach to the patient that I think really helps them avoid those patient harms. Patient harm that comes from the traditional things that we think about when it comes to like injury to body or other things, but then also making sure that people do get to where they need to go as direct a line as possible. Making sure that when folks walk away from the healthcare experience, they're not re-traumatized, and when they return to engage with providers, you're building on positive experiences instead of negative experiences that you're trying to bury next time that you see somebody for getting help that you need. So I'm hoping as people think through this, they think about concrete examples of how they can act in order to create culturally safe environments, because I think the last place you want to be when talking about this is like remaining in abstraction. These concepts, I think we're realizing they really do have a big impact on whether or not people thrive when coming to get care in the healthcare system.
Thank you so much, Alika. I love that. And I like when you think of concrete examples of if those that are here today participating, that are listening, consider that team approach that you talked about. Like, what is something concrete? Maybe it is approaching cultural safety from a team, whether it's a team working at point of care or in leadership or what have you. So I like that as sort of being one of those things to consider in a starting place. And both you and Bobbi have mentioned the idea of trauma informed and really considering what that looks like, that awareness looks like, and sort of preempting and not re-traumatizing people who are coming into our care. And I'm just wondering, Reagan and Lynn, if either one of you want to also share sort of your perspective and sort of explore these connections of cultural safety and anti-racism to patient safety, and how culturally unsafe care can contribute and cause harm.
I think if I can go, Lynn, I don't want to jump in without your consent here. I'd just like to pick up on something Dr. Lafontaine that Alika had mentioned about concreteness, and you had brought up that concept of trauma-informed care. It tends to be quite a buzzword within the patient safety realm. And so, I challenge the folks that are listening today to do the work. What does trauma-informed care mean? And it's not just a definition. It's not a tick box. We used to get there with cultural appropriateness or cultural awareness, and we realize that that's not enough. It's not enough to say you're trauma-informed. What does that mean? It's about positionality. It's about recognizing your own inherent biases. I myself, as a Métis woman who is not a mother, but is an auntie, who has a position of power, I need to look at those things whenever I'm providing care, even within my own community. So there are concrete actions that start with having a better understanding of what we're talking about. So those buzzwords, if you're starting to hear them, maybe a simple place for you to start as a concrete action that can support patient safety is actually taking the time, prioritizing, better understanding what these terms actually mean, and then looking within yourself and looking to your neighbors. Who are the communities that are around you? Get to know them in those spaces, and then apply those definitions that you've now digested, had a chance to reflect upon, and put those into play. When we talk about patient safety and cultural braveness or cultural safety, it's about taking a step. I think we often get paralyzed because it's such a wicked problem. So those are small things that we can do that Dr. Lafontaine said, concrete doesn't have to be solving the problem. Concrete is taking a step. And you know what? Once you take that first step, the second one is easier because you'll find allies along that journey. You'll build those relationships, and you'll start to create a new culture where we center the person and their experience and how they feel in care again. We used to, but we're missing that. And so those are my thoughts that I would contribute to the discussion.
Thank you so much, Reagan. I love that. And starting and how I think it is quite daunting, this idea of equity and cultural safety. I love the term cultural braveness. I love that. And starting in that one place, and how we think of, in healthcare, we always have measurements and evaluations and things like that. And sort of considering that maybe measuring in millimeters, not miles, is the place to start. So that's great advice for those that are here today. And Lynn, I'm wondering if you'd like to share any of your thoughts and perspective.
Well, I really appreciate the lens that's coming in through from people who are actually within the healthcare system and seeing where it could be improved, and seeing it from the patient side and hearing how patients have experienced what they're going through. It is very much, they want to be heard first and respected by the person who's on the other side, considering they know that, it took them probably months or years to get to even to that doctor, to get the care that they wanted, and then just feeling comfortable enough to express. And then that person hearing what the patient is saying. And I think putting all those biases down, like everybody else is saying, and just appreciating how long and how far somebody has to go just to get that first time doctor's appointment or specialist appointment. And then just maybe not thinking it's just one car ride. It could possibly be a 5,000 kilometer ride of 3 days of travel, and staying in a place that you may not necessarily feel comfortable, but you have to be there in order to go to your doctor's appointment. But I think when people bring it back down to the basics, I think it makes it so much easier to have a conversation. I hope that helped.
That's great, Lynn. Thank you so much for that. And again, I think talking about those millimeters, not miles, and what are some things we can do right now in space to create some change and awareness for what's going on. Thank you so much for sharing that. And so now I think maybe, Reagan, if I can talk to you and sort of pose this. You currently work as a director of health for Métis Nation of Alberta. You've also had the opportunity to work as an intensive care nurse for 16 years. I mean, that's quite a breadth of experience. And I'm just curious from your perspective, how we understanding how racism and culturally unsafe care contributes to patient safety incidents specifically. What are the protective health factors for Métis culture or of Métis culture based on your experience?
I'm just going to position myself with the knowledge from my community. So I have the voices of about 65,000 Métis folks residing in Alberta, but I would never presume to say that this is, the entirety of Métis culture. There's a lot of diversity and inclusivity across the Métis homeland. So I just want to caveat that so that nobody comes for me saying that I've put words in their mouth. If you haven't talked to me, these are probably not your words. But one of the most incredible things that I have come to know and embrace about our Métis culture is that importance of relationships or relationality as culture. So that as a protective factor is where we start within our community. There are close-knit kinship, community, and social ties that we share through our unique culture and our experiences as Métis people, but also within these colonial systems and experiences that we've had. Métis people as a community, as kin, are a cultural strength that I think can be leveraged in the health arena. Those social connections, whether it's family or friends, or even organizations and governments like the Otipemisiwak Métis government within the Métis Nation, offer those safe spaces to gain traditional knowledge, to ask questions, to vent without fear, to navigate systems that don't make sense through those connections. They also offer opportunities to laugh and share stories and food, which are also part of our culture, which obviously have more obvious benefits to health than a social connection. But social connection, as we saw during the pandemic for our community, when we experienced the removal of that protective factor, was a primary driver for Métis well-being, particularly for our elders and seniors. And the reality is, that's not something that our system is set up to support today. Relationships and relationality, we hear of times gone by, even, I have a baby face, but I am not a baby. I remember when doctors had the time and capacity to do home visits. They knew who was part of the family. They were allowed to have that time. And the system, with our population growth and with our KPIs that we have to meet, and all of the patients that physicians and nurses and other healthcare providers are responsible for, we've had to set some of that relationality aside for time. And it really has impacted cultural safety, specifically for our Métis community, who likes to sit down and say, hey, my grandmother was born in Batoche. I'm a Patress. Oh, you too? Let's have that conversation. Or if I have a First Nations physician, I can talk about the differences of where we came from and have that moment where we laugh about, oh yeah, my grandma made me eat that too, and it was horrible, but wow, I wasn't sick when we did it. We're missing that now in our system because we are catering to time constraints and we haven't caught up with population growth. I think relationality as culture, though, extends beyond a connection to people. It extends to land around us, the places and spaces. It's about more than just providing care. It's about the spaces we provide those care in, and it offers us that ability to kind of supplement our diets. So when we talk about, kind of tangible things, we know our community is still supplementing with, harvested and gathered traditional foods that we know contribute to well-being. It extends to our ancestors' relationality, right? So that spiritual component that is so deeply ingrained in our culture, however it is defined by an individual or a family or community, I think is a cultural connection to wellness. And it's hard to quantify that, which makes it hard for the system to take it up. We are strength-based in our culture. So the deficit-based way that a lot of our health system greets us, with probing questions that are just designed to save time and get to the problem. I'm a nurse myself. I've used that technique a million times, but I know that that's not culturally the way we are. We tend to start with greetings and families, getting to know each other and those strength-based components about what's good in our lives before we start working on, what our actual problem is. And again, we don't have that space. Unfortunately, resiliency has become a part of our culture. We hear that from our community. I wish that it wasn't. It can be exhausting to be described as a resilient people because it means that you've been forced to have to be. And so I think that is part of our culture that impacts cultural safety, is that, nevertheless, we persist, we're still here. And that is something I think that supports. We've also heard things about culture in terms of language as a protective factor for our community, particularly in areas of mental well-being. If you can't communicate effectively and be understood, Lynn kindly said, people want to be listened to and heard and respected. And that can be very difficult when your first language is Cree or Michif or another First Peoples language, and the system isn't set up to guide you in those spaces. And finally, I think one of the strongest points other than relationality is identity, celebrating who we are. That sense of pride is considered a protective factor for our Métis community, at least as they describe it to me. And often that gets put aside and swallowed. Look at me. I mean, we know that there's a diversity of visible looks to Métis people across Canada. If I put my hair up and I don't say I'm Métis and I take off my sash, it's really quite easy for me to just kind of blend in and not worry about whether or not I'm going to be receiving care that's racist or discriminatory. But really what that does is that removes the protective factor of who I am. I'm taking off a Métis hat, and I shouldn't have to. And so, celebrating who we are, that identity, is a protective factor for us. And so systems that are set up to celebrate alongside us are going to be more effective than those that don't. And I think that's maybe where I'll leave it.
Wow, Reagan, there's a lot in there. This idea of positionality, starting with positionality, relational, that relationship and to who people are and to their community, and then this idea of identity, and not having to strip away identity, because that is how we have relation. I think those are some really profound words of wisdom. So thank you for sharing that. And this idea of relationality beyond culture, that it encompasses, again, seems to be this wholeness, this conversation that we're having today. And resilience, I know, is even in, with the distressed workforce as well. It's like, it seems to be seen as it's like a 4-letter word right now. So, what are we doing to activate this resiliency, or if that identity is part of those protective factors, maybe some different terms we can start using to profile that and to share that. And so, Bobbi, maybe I'll turn to you. And I know you support the seniors in northern and rural communities in Alberta. And Reagan sort of mentioned this idea of a social disconnect that occurred during COVID. And thinking about seniors in northern and rural communities, can you talk about the intersecting identities of older adults, people living in rural northern regions, and Métis people, and some of those experiences of how accessing care is different? Based on a conversation.
Sure. So, for those of us that are maybe a little bit older, like myself, I will actually first talk about what intersectionality actually means. I know it's a term that originated probably in the 80s, but really has only been used within the last 8 to 10 years. Kind of as coming to the forefront when we're having these conversations. So basically, it's the concept that all oppression is linked, that there is an interconnected nature of social categorizations such as race, class, age, gender, kind of all of those things that create an overlapping and interdependent systems of discrimination and disadvantage. So basically, for us, it means it's the acknowledgement that everyone has their own unique experiences of discrimination and oppression, and that we need to consider everything that makes up that kind of all of those things that can that would result in the marginalization of people. So anything, gender, race, class, sexual orientation, physical ability, age, all of those things, and how they kind of overlap and interact with each other. So as for your question, it's well documented with current data that the lived experience of Indigenous people, that despite growing acknowledgement and efforts to improve cultural safety, the Canadian healthcare system continues to often fail to adequately address the social and health inequities, and it remains susceptible to be influenced by those things: race, ethnicity, culture, physical appearance, all of those things which can lead to health disparities among our Indigenous populations. It's also well documented that a large gap exists in the health status between the general Canadian and our Indigenous populations. Indigenous seniors face multiple disparities, such as lower socioeconomic status, poor health status, shorter life expectancy, all than the wider Canadian population, all of which can affect their social, physiological, and emotional well-being. In general, rural populations in Canada also have lower socioeconomic status, lower levels of educational attainment, and higher all-cause mortality rates compared to urban Canadians. And then in addition to that, disparities exist between our Indigenous and non-Indigenous and rural and urban areas in terms of access to utilization of healthcare services. So despite the higher prevalence of disease and mortality, many Indigenous communities actually lack sufficiently qualified healthcare practitioners, which creates a situation where patients may not get the appropriate and timely diagnosis of complex conditions. Also puts them at, a higher risk for an unsafe healthcare environment. Many rural and remote Indigenous communities across Canada not only offer healthcare services led by nurses, by a nurse in charge or a nurse practitioner, rather than a physician. And in these communities, nurses usually have to, because of those restraints, and they prioritize providing acute care rather than providing emphasis on education and preventative services. So in many of our northern and rural Indigenous communities, physician services are only offered on an outreach basis out of a larger rural center. And my area is definitely included in one of those. Limited physician interactions lead to limited access to specialist referrals and inadequate follow-up for chronic and serious health conditions. And then there's the side of things in regards to discrimination. So healthcare providers often don't acknowledge the impact of colonization on the Indigenous communities, or sometimes they're in a situation where they disregard those social determinants of health as explanations for illness. And both of those things can serve as a deterrent from accessing healthcare services until it's absolutely necessary. So often that means when our people finally do go in to see the doctor, their health is far worse than the average person would be, who would be accessing that care sooner. Many of our Métis elders have suffered direct impacts from colonization as residential school survivors, and due to the racism and trauma that they've experienced in their lives, they are less likely to question the authority of a healthcare worker, less likely to demand the standard of care that most Canadians would expect, and more likely to feel like a burden or nuisance when they're accessing healthcare services, when they're asking questions about their health, which also can be a deterrent for seeking care. And then, of course, Lynn had referred to the distance being a deterrent, which is huge for us in northern rural communities. Accessing healthcare is also influenced by access to transportation for anyone and everyone living in northern rural and remote communities, but it's especially challenging for our seniors. The lack of available affordable transportation, coupled with the distance and the occurrence of medical appointments, really does impact healthcare access and the ability to attend those appointments.
Yeah, that's a lot, Bobbi. That's a big conversation. And I'm just actually curious, Lynn, when you reflect on what Bobbi's sharing about those barriers and challenges and some of those statistics just from a lived and living experience, I would love to hear your voice in this conversation.
Well, the same amount of challenges, but think about it, not just elders, all patients. So that's infant to senior and for any kind of specialty. Nunavut is nurse in charge, unless you are in regional centers or if you happen to live in a Kilabuk where there's an actual hospital. And then you can get expedited from there, but you still have to get through from your community nurse in charge and hopefully get heard on what your symptoms are. And hopefully there isn't any already community bias, cultural bias, and family bias that's already happening for that person in order to get that care, to come down and get that specialist appointment, or even just a doctor's one. And then there's the rotation of doctors. There's only so many doctors who will stay in one region or one community on rotation. So you might be now talking to the 5th doctor that's coming up for that rotation, which Bobbi's really talking about, which Nunavut Mute are exposed to. If you live in Iqaluit, the capital, you may get the same doctor for maybe 3 years. So those challenges put forth to someone, and she's right, feeling unsafe, there's authority, there's trauma. People are worried their children are going to be taken away. Some people may not even have the, oh, I didn't know what I was coming down to get done because I wasn't informed which appointment this was. So you go to the doctor and you don't know what you're going to be told when you get there. Unless someone is organized, always asking, but that's a family member advocate for you. And some people don't get a family member advocate. Or if they're getting, I always called it the worst or the best news of their life, because you're right, they usually sometimes don't get care till they're far progressed into their illness or their prognosis. And the doctors are like, okay, I only have 15 more minutes. So what's going to be the care? Well, the care involves your whole family, your whole community, because people are going to have to take turns to bring you to those visits that you have to fly out for 3 days to get them. So I think if the healthcare system understands that, and it takes more than one visit to make a decision, that's the community, that's the family care, that's the everybody involved that Alika talked about as well. That's what Reagan talked about. Well, it takes a whole community to take care of people. And that's how Inuit see it. And that's how a family would have to see it, because people can lose jobs helping a person going for health care because they're gone too long. So you want to be as respectful and listening to what that person, what decisions they have to make while they're there.
Thank you so much, Lynn. And it's really important. I think we highlight those experiences are real, and what can we do to support services considering that. And maybe I'll look towards you, Alika. You're the immediate past president of the Canadian Medical Association, and Lynn and Bobbi have talked a little bit about some of those barriers and challenges in care and professionals that are in those systems. So we've been talking about how racism and culturally unsafe care has impacted patients. So I'm just curious, and then actually a question came up as well in the chat, I believe, around other Indigenous physicians have shared their own experiences of racism working within the healthcare system. And how does the cultural safety of the work environment impact the safety of care delivered to patients? And one of the questions actually in the chat was, are medical schools, or is anybody actively working to create interest and encourage and support Indigenous people with a view to recruiting more physicians in this space as well? So sort of a two-pronged, like, yes, there's this experience, and then how are we also encouraging Inuit, Métis, and First Nations people to come into the world of healthcare to provide those supports in the community where, as Lynn mentioned, people feel the safest and they've got this centering of family and community. So I'm just sort of curious from your perspective, Alika, if you can share a little bit about that.
Yeah, I really appreciate the sharing from the other panelists. I think it really grounds the discussion in like the real world versus just talking about theoreticals, right? And one of the things that I always try to communicate when I'm talking to health leaders is we get the healthcare that we design, right? Why in the 70s did we fly Inuit patients down south, sometimes as far as like the distance between Winnipeg and Los Angeles, to some foreign place where they were by themselves? People didn't speak their language. No one was sitting down helping them to understand cultural norms or how to utilize things properly, because very foreign ways of doing things when you come from traditional remote communities in the north, down into the city, instead of just creating opportunities to receive care in your own community. Well, it's because we just chose not to build stuff. Like if you look at Indigenous communities across the country, one of the things that has always struck me is that in a lot of places, if you have a town and you have, say, a reserve, the town always gets the clinic. It doesn't matter if the town's smaller than the First Nations. It doesn't matter whether or not people have a good experience going to the town. All the resources get poured into places that are not on reserve. In Saskatchewan, where I was born and raised, there used to be a policy within cabinet just not to invest in healthcare infrastructure on reserve. If you look at Indigenous Services Canada, and prior to that, First Nation Inuit Health Branch, there's a policy that has been in place for a lot of years that I think is shifting now, but the only health provider that they would fund would be nurses. And so you then ask the question, well, why do you not have physicians in the north? Why do you not have team-based care beyond just having nurses who are quite competent, I think, in a lot of places and work really, really hard, but why are they left alone without any of the support that they need in order to provide optimal care? Well, because we just chose not to fund it. Like, that's how we designed the programs, and it ends up having really enormous impacts. If you have a nurse who's running a nursing center and they're providing acute care, if that nurse can't call someone for help and guidance when it comes to something that's beyond their scope, and I work in Grand Prairie, I send people down to Edmonton and Calgary, not irregularly, because their needs are beyond what our facility can have. So I don't think it has anything to do with people's willingness to help, but if they can't get on the phone with somebody, they're going to have to send someone down by plane because they don't have someone available to consult 24 hours a day, 7 days a week. Those are all things that we've designed. And so I think shifting our view away from the idea that all this stuff happens because that's just the way that it always happens, it's really because we designed it that way. And circling back to what we're talking about, if you have a culturally unsafe environment, it's because you created that culturally unsafe environment. Why does a provider feel that they can use a slur or they can be offensive to someone? If you look at Joyce Echequan and her experience in the healthcare system, and I don't know if folks have actually watched the 12-minute live stream. The most terrifying part of that whole thing was at the very end, when the person who was mistreating her looked at the phone and picked it up to turn it off. There was no fear in their eyes that the phone had been recording. They thought everything they were doing was just normal. And I think that there's two things that I always remember when it comes to creating those environments where folks can receive good care. The first is that when you have culturally safe environments, it's not just good for the patient, it's actually better for the providers too. How horrible is it to come to work and provide care for folks and have this high level of tension and dislike to the people that you're supposed to serve? So that's kind of the first part. And the second part is, I think that experiences of racism, when we don't work through them and talk about them openly, and share them, we start to mix up, just negative experiences versus racist experiences. Lots of folks across the country are waiting, 6 to 8 hours in an emergency room in order to be seen, right? That is a negative experience. But is it always rooted in racism? Well, I don't think always. Sometimes it really is. People are just completely overwhelmed and everyone is kind of having the same sort of crummy care, but if you never talk through with people the realities of where we're at right now with the healthcare system, they'll take the trauma that they experienced in the past and it'll pile on new trauma, when in reality, if you talk through these issues, they'll start to maybe see a different perspective than they had before. Culturally safe provision of care allows providers to see things differently, but it also helps you to have a different relationship with your patient. It helps them to see you as well. And I look around at colleagues who, you know, are talking about low morale and just not feeling like they're enjoying providing care anymore. Fellow physicians, nurses, you know, all the other folks that work in the healthcare team in the hospital. And I think in culturally safe environments, like, you actually do start connecting with people again. You feel like you matter to them and they feel like they matter to you. And at the end of the day, that really is the environment where you can provide the very best care.
That's amazing, Alika. Thank you for that. I'm like writing feverishly down. I like the idea of, you know, people are going to have experiences of racism and being able to talk through that, you know, having those opportunities to talk through that and what that looks like. And I like the idea of, you know, providers, we, you know, see you and are seen as well in that, and that this idea of connection, you matter, I matter, this idea of a team-based approach to healthcare that we're talking about. Thank you for sharing that. I'm wondering, Reagan, if I can go to you. I know you're part of the Métis Nation of Alberta's team that led the COVID-19 response. And during this time, you and your team rolled out the first Métis-led vaccination clinic in the country. And I'm just wondering, when we're talking about team-based care, we're talking about you matter, I matter, you know, this idea of a Métis-led you know, sort of initiative seems foreign to all of us, but I mean, no surprise, right, that this is the right way to do things. So I'm just wondering what elements of cultural safety and anti-Indigenous racism were incorporated from the beginning, because I think it seems like it was a very thoughtful process.
Well, I mean, it doesn't seem like it's a surprise to us in Métis community. We've always known that we have the ability to care for each other. I think that's pretty universal for a lot of First Nations, Métis, and Inuit communities. It's like Dr. Lafontaine said, if we're given the resources and we can build it in a good way, then it will be done in a good and culturally safe way. So the opportunity that was afforded to us because of the pandemic, I mean, if we can look for a silver lining in the pandemic, that was it. We were given the resources, and we describe it as a hug with a clinic in the middle. When we talk about the protective factors that I previously mentioned, the relationality, the relationships, we know that historically there are folks that struggled with mistrust of our health system for absolute good reasons. Colonialism and assimilation of First Nations people, Métis people, and Inuit people, we know it happened. And so there's that understandable mistrust. But what we did was we took it out of the hands of the health authority. We were the drivers. So that concept of self-determination that people might see as a buzzword and self-governance over health services, we actually put into play. So rather than appointments being booked, something as simple as an appointment platform, it was booked through the M&A. So folks felt comfortable phoning us, asking questions about the vaccine, and booking appointments, and they didn't have to identify within the system because folks are scared to do that in a lot of cases. So we took that out. So that component of by community for community as a part of cultural safety was absolutely put into place. The relationship between location or place I talked about as a protective factor, we didn't have it in a clinic. We had it in a space where we typically host our cultural gatherings. So it was a space that folks already connected to in a way that wasn't uncomfortable. This is where we came to share food. This is where we came to dance. This is where we come to hear about the successes of our nation. Well, now it's where you come to have a vaccination. You can still do all those other things because we did incorporate food at the end, you know, traditional, you know, iconography and music, things that bring us comfort, but are not necessarily inherently culturally safe. It was because it was happening by community for community. We also made sure that we had Métis healthcare professionals on site. So we had Métis nurses, we had Métis physicians. A huge shout out to the Indigenous Wellness Corps in Amiskwichi-Waskagan, because they did provide Indigenous physicians that were on site that were able to answer questions in real time, so that if folks were on the fence, they could get trusted information that day. So we made it accessible. We supported folks getting to the clinic. So we talked about barriers being transportation to and from clinic. We had folks traveling upwards of 8 hours from across the province because they felt safer receiving an injection for a COVID vaccination from our community than they did from the regular healthcare system. I feel like you can't get much more of an endorsement from community than that they're willing to take that time to do that because they knew it was a safe space to do it. I talked about cultural safety, but I don't want to forget the folks that are non-Indigenous. We had incredible healthcare practitioners that were kind of sandwiched in the middle of our clinic that were providing the actual injections. Some were Métis, some were First Nations, and some were just incredible allies who were non-Indigenous. But we took the time to describe and be trauma-informed by discussing, hey, do you know why this clinic is so important to our community? Do you know the historical traumas that are associated with medical experimentation, acute care, all of those things within our history? We made sure that the folks who were providing the injections that day and care for our community understood why our community might be vibrating when they come through the door. It's not just the pandemic, it's colonization. And so we made sure they had that understanding, and we made sure we were there for them too. And that's that relationality again that is so central to our culture and our people. We want to make sure everybody is okay, that nobody is left behind. And so we prioritize the staff having that understanding of who we are as a people, what our colonial past and our contemporary colonial interactions have been, so that they actually felt comfortable providing the care to our community alongside us. And so I think those were the key ways. We also, COVID came out, there was a lot of, fear over would we have enough vaccine? The result ended up being a lot of security everywhere. Well, you can imagine with the colonial history of the RCMP and how that went down, that seeing folks in uniforms at a medical clinic is not exactly providing safe care at all. And so our community were the ones doing the COVID screening. Our communities were the ones, if we had any sort of escalation or discomfort that, kind of physically manifested, which we had none, or verbally manifested, which we had none, which again is an evaluation of our clinic. But we were prepared to de-escalate ourselves amongst communities, as we do when we're in community. So it provided that safer space. Data sovereignty was respected. All of the information aside from the immunization records, about where people resided and booking appointments and such, stayed with us. And we saw family units. So when we knew we had, Métis elders or knowledge keepers or folks who were immunocompromised, within any age group, we ensured that their families were also immunized so that they could continue to provide that community-based care. It's not enough to protect one person. We recognize that those kinship and community ties are important. We worked all of those things into the clinic and prioritized a celebration of the fact that we had an opportunity to protect one another rather than just a sterile clinic, with X's on the floor. We had people. And I think that's part of what we remember when we build these programs and services. You're not building them for a KPI. You're building them for, as Bobbi said, how people feel, how people show up on both sides. Because I can tell you right now, the AHS employees also verbalized that they had a much better experience working at our clinic than they do at a regular vaccine clinic. So when we look at these kinds of things, we often, I've heard people say, well, if we do that for one person, we have to do that for everybody. Yes, you do. You need to provide cultural safety, racism, discrimination free, excellent care to everybody. It just happens that maybe, just maybe, Indigenous people have something you could latch on to. Maybe our ways of being and knowing aren't so foreign. We might just call it something different, but the feeling will be the same. And so that is what our clinic achieved. And it isn't rocket science. It's exactly as Alika said, it was an investment in the right places. It was doing things in a good way. Now, can I say that that's happened again? Nope. Have I had an opportunity to run an influenza clinic? Nope. No, I haven't. Why? Maybe that's a question for folks who are in the chat boxes, what is your organization doing to look at these really simple, concrete actions and investments? Because I can tell you, I had an 80% immunization rate within my community because I ran a clinic. Wouldn't it be great if we could do that for influenza and not seeing influenza A run rampant through our acute care centers right now? I could help with that. But guess what? We're not being prioritized again. So those are some of the lessons we learned from our clinic. Thanks for asking.
Reagan, that's so great. I love the hug for the clinic in the middle. I think KPI, can I suggest everybody we start thinking about, is that like kind people included, key people included, care people included? Maybe KPI needs to be changed, you know, how we measure this work, and just put it out there. I did want to let the panelists know that the chat is, and for the participants, the chat is not public. However, panelists, there have been some extraordinary comments and thank yous and gratitude to all of you for sharing your stories and for speaking to a lot of these areas. And I know we have sort of about 15 minutes left, and I really want to have an opportunity to ask each one of you, and maybe I'll start with Bobbi, some key takeaways or hopes from this conversation in moving some of this work forward based on the conversations we've had today. So Bobbi, maybe I can start with you here.
Sorry. I think as for a key takeaway, I really appreciated everybody's input and feedback. I don't think there's one specific thing that that was more valuable than anybody else's input. And I think that I really appreciate having been invited to participate in this panel. And I also really want to thank the participants that have registered and that are showing up here today to listen and to learn. I did kind of want to, I guess, having worked in the healthcare field for 20 years, I understand that a lot of the participants that registered today are from the healthcare field, healthcare workers. And I understand that, you know, a good lot of you are understaffed, overworked, and that the extra time to commit to learning opportunity, to taking the time to make time for learning opportunities like this, they're few and far between. I want to thank them for making the time this morning to listen and to learn with us. And to maybe I'll just take the time to kind of make a point that if there is one thing that I would like them to take away from this, in all of the little things that they could do, if they have in their limited amount of time, if they could just what I would like to tell them is to just be respectful, be understanding, and be kind to everyone. You know, like Reagan said, it's not rocket science. Treat every client the way that you would want your family member to be treated. All of the organizational policies and inclusive environment initiatives in the world mean nothing when members from our community walk into the ER for real health concerns and we're treated like addicts looking for a fix. That one small change that anyone who's attending can commit to, that's the change that will eventually change the culture and the safety of our healthcare system. And that's the thing that will most impact the lived experience of racism for our Indigenous patients.
Thank you, Bobbi. And Lynn, maybe a quick 1 minute hope for the future or takeaway from today.
Totally echo what Bobbi just said, but as well, you know, First Nation, Métis, and Inuit are different, and it's okay to ask if you are First Nation, Inuit, or Métis. Inuit take pride in saying they're Inuit, so it's okay to ask, as long as you're doing it in a safe and respectful way. Our numbers are less. We've been colonized not as long, but all our same challenges are the same, I believe. And we all want the same thing, to be heard and to be acknowledged when we want to express how we would like help.
Thank you so much for those words, Lynn. Alika, your 1 minute hope for the future or takeaway from today.
Yeah, you know, the thing that I keep on coming back to is that it's about showing up, you know, and I'm thinking about a quote that I was told from a residential school survivor that I had done some work with in Saskatchewan, and we were talking about trauma, and I was asking, you know, how do you get people to share, you know, the things that they're going through? And what he said was, you know, people who have experienced trauma want to share what they've gone through, but people just aren't ready to hear it, and so they don't share it. You know, so I wouldn't overcomplicate a lot of this stuff for folks who are trying to make things better for people accessing care in your area. You know, show up and prepare yourself to like hear about people's traumatic experiences and, you know, their frustrations with the health system and other things. They will share, you know, and if you show up, they'll show up too, and you'll build something a lot better.
Thank you, Alika. I really appreciate that. And Reagan, your 1 minute takeaway or hope from today's conversation.
I think my takeaway for everyone is a word of encouragement, because these conversations can be heavy and you can feel paralyzed and not know where to start. But I think it's like Dr. Lafontaine said, just show up. Remember that you can be responsible for your own integrity, how you work, how you look at a policy, how you interact with a patient, a family, community. It matters. It's that concept. I was fortunate enough to do some nursing in Ethiopia, and they had this concept of a drop in the bucket. You know, sometimes we felt like we were doing things and it was just a drop in the bucket. But if you fix the holes in that bucket, every single drop will stay in there and it will add up over time. And then you're going to have a full bucket and indeed an overflowing bucket. So I encourage you to start small with yourself. And then you'll find that once you've got yourself sorted and you're working in a good way, new staff that are coming up are going to see that modeled, and they're going to be inspired, and they're going to want to be the caring, compassionate healthcare professional that you are. And then guess what? Those same caring, passionate professionals move from the front line into higher level positions. And that drop, that bucket, it follows them, because now they are the change makers in a different space. And that integrity, that work that you've done personally, now translates into policy changes that are more culturally safe for our community members. You know, it might look like more educational hours for staff, because you've thought, what would I have needed? What did I need to be that kind, compassionate person along that journey? So my word of encouragement is just be that drop. Be that single drop in the bucket, because it adds up. So just look to your own heart, right? And be responsible for yourself, and it will follow. That's a small step. You don't have to solve it in one day. Just be a good person.
Thank you, Reagan. And thinking of our hearts today and the conversations that we've had, and to our audience, thank you so much for tuning in. I do encourage people to stay, don't go anywhere. We have Monique Minach coming back to close us off in a good way. And again, thinking of our heart, just taking that breath and really wanting to do this in a really well way to end this incredibly enriching and wise conversation today. This can be an opportunity with Monique to really help us process what we've heard in the hour and a half that we've been talking. So thank you very much for the excellent and engaging conversation. We hope that you found the session informative. You will receive a follow-up email with a link to the recording that you can share with your colleagues. And I know there were questions about resources from the panelists that were mentioned, so we will include those links. Your feedback is incredibly invaluable to us for future sessions to design. So we ask that you please just take a moment now to provide us feedback on today's sessions. And we're going to throw up a poll. The 5 poll questions are going to come up on the screen. And we'd love to also hear from you in the chat or by follow-up email. So if we can have that poll come up. And once again, I want to thank Reagan, Alika, Bobbi, and Lynn for your reflections, for your wisdom, for your generosity today. And thank you as well to our audience for joining us today. So we'll put up that poll. And then I'm going to welcome Monique back in a minute. Great, so whenever the team wants to close that poll. And then if we can invite Monique in to close us out in a well way. And again, would love for the audience to stay for us to all reflect as Monique shares her wisdom.
Kachimi-gwich, thank you. This has been a very touching and heartfelt conversation, very courageous one. It's difficult to talk about these things without becoming vulnerable and having it impact you and impact me emotionally. I've seen firsthand with family members the challenges that are faced in healthcare, especially in Quebec. And the idea of this is the system that we've created, and so we can create a better system, I think is just brilliant. And although harder in reality to change, but I think it's something we absolutely, it's essential that we do this. And to see these people here today who are so committed to making those changes, I just, it's very touching. And I really appreciate all the hard work and commitment and dedication and personal sacrifice that it takes to do this kind of work. And so I'll close the space with a few words to the Creator. Kachimi-gwich, Jemnido, thank you, Creator. Thank you for the water, for the plants, for the trees, for the ones who fly, for the ones who swim, for the ones who crawl, for the furred, for the feathered, for the four-legged, and for the two-legged. And thank you for bringing everyone together here today with open hearts, with open minds. Help us to see beauty. Help us to hear truth. Help us to speak with kindness and with compassion, and help us to work together for the benefit of all of our communities. Kachimi-gwich, 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 Kachimi-gwich. Thank you very much. And if there's anything you want to reflect on, please feel free. Thank you.